Hello, dear students. Hope I'm audible. Hope my audio, video, everything is clear. Hi. Good evening, everyone. How are you, people? Okay, perfect. Everything is good. So, welcome to today's session. What we are going to do first, let me explain what we are going to do. Right. So, what is this clinical pharmacology? What and all I'm going to teach you, people? I'll tell you about that first. Once I tell you about that, let's talk about the other things. Right. Okay, now listen to me very carefully. What we are going to do is that in this lecture we will cover up such aspect which includes with your pharmacology. That is the first thing, and also there are some points which will come from the side of medicine and also from the side of pathology. So I'm trying to cover everything in one place. All right. So that is going to be our target. Now the next thing. For your exams, be it a NEET, be it your FMG, whatever the exam. So for all of the exams, most important highlights and previously tested concepts I'm going to explain you people today. Okay. So hello everyone. So without any delay, let's start today's session. So when we're speaking of heart failure, see, this is a very interesting disease, but the important aspect is, see, this is a disease which does not have, for example, one particular set of symptoms. Rather, it has a big range of a spectrum of symptoms, right? So most of our cardiac diseases will have that only, but the spectrum of diseases, like symptoms, how will they start? What are the reasons? And let's understand with the basic introduction. So first, let's start with the most important thing. What is a heart failure, my dear students? See, whenever we are speaking of heart failure can be acute heart failure or a chronic heart failure. But for us, the most important one is acute heart failure. So for that to understand, I want you people to learn the first and most important concept. What is a heart failure? What happens in a heart failure? So here there is, my dear student, there is a decrease pumping capability. There is a decrease of what? Pumping capability. So decrease pumping capability of the heart. Okay. So if there is a decreased pumping capability, what will happen? Let's see, right? So when we are speaking of decrease of pumping capability, what happens, my dear students, with the heart is a very important concept. So please listen to me very carefully. If there is a decrease of pumping capability of the heart, because of that, what we are going to encounter, so there will be decrease of blood supply, decrease of blood supply, decrease of blood supply. So there is a decrease of blood supply to which part of your body? Remember, there is a decrease of blood supply which will lead to decrease of O2 supply to the organ. Decrease of what? O2 supply. If there is a decrease of O2 supply, now what will happen? Will your heart be able to meet the metabolic requirement? No, not able to meet the metabolic requirement. Not able to meet the metabolic requirement. Okay, so required oxygen, so that is the most important, required O2. Okay, so not able to meet the required amount of O2, that is the most important problem with your, what is that, heart failure. So if there is a decrease of oxygen supply, what will happen? So the most important pathology behind pathogenesis of the heart failure. So in the pathogenesis, my dear students, what we must know, so the important aspect is, see, we have some of the most interesting aspect because it has two ventricles, right? So if there is a two ventricles, there is the failure of two ventricles, means both the ventricles are not able to pump the blood. So what will happen? Let's see, right? So in this particular aspect, the most important point, my dear students, the pathogenesis, you need to understand the first and most important, there is a decrease of cardiac output. There is a decrease of, what is that, cardiac output. If there is a decrease of cardiac output, because of which what will happen in the body, that will trigger a cascade of changes. So if there is a decrease of cardiac output, now I want you to understand what will happen. Cardiac output is reduced. If cardiac output is reduced, what will happen? There is a decrease of perfusion. There is a decrease of perfusion to the organ. If there is a decrease of perfusion and if there is a decrease of cardiac output, that will immediately activate one system, that is only, my dear students, sympathetic nervous system. It will activate which nervous system? Sympathetic nervous system. If there is the activation of sympathetic nervous system, what we are going to encounter? So please listen to me. The sympathetic activation will create one of the most important aspect. What is that? The activation of sympathetic nervous system will activate somebody called as beta 1 receptor. Will activate somebody called as beta 1 receptor. And if there is a decrease of perfusion, that will also lead to one more problem. That is only decrease of renal blood flow. Decrease of which blood flow? Renal blood flow. So beta 1 receptors are also activated, and also there is a decreased blood supply to your kidney. We call it as a decrease of renal blood flow. Remember one simple rule: whenever there is a decrease of cardiac output, that automatically reduces the blood supply to the multiple organs. So one of the most important organs which will be very sensitive to the blood supply is your kidney. So if there is a decrease of blood flow to the kidney and beta 1 activation, because of these two factors, they will stimulate the release of renin. Which substance? Renin. So this renin, whatever is released as a result of beta 1 and also as a result of decrease of renal blood flow, it will do one interesting thing. It will convert, my dear students, your favorite system, that is RAAS system. It will activate the RAAS system. So it will activate the RAAS system by doing this. So it will convert angiotensinogen. So for all of you who are studying your MBS first and second year, any word if it has a gen in the ending, that is most likely it is what? A inactive substance. This will be activated into something called as angiotensin 1. What is that called as? Angiotensin 1, right? So this angiotensin 1 will get converted by the help of an enzyme called as angiotensin converting enzyme. It will convert angiotensin 1 into something called as angiotensin 2. Very important. Okay, so we have now, what is that? Angiotensin 2. Now this angiotensin 2, whatever is there, remember this is a very important aspect. It will go and activate production of your aldosterone. Now we have aldosterone, and also, my dear students, it will go and activate somebody called as very good. What is that? 81 receptor. They will activate what? 81 receptors. Once the 81 receptors are activated, that will cause vasoconstriction. It will cause, what is that? Vasoconstriction. So because of the vasoconstriction, what will happen? That will automatically increase the peripheral vascular resistance. So this is what is going to occur during, what is that? RAAS activation. Now this aldosterone, my dear students, what it is going to do is an important question. What is it going to do? It will cause the increase of sodium and also water in the body. So if there is an increase of sodium and water in the body, that will increase the circulating volume or increase the plasma volume. Increase which volume? Plasma volume. So plasma volume has been increased. If the plasma volume is increased, that will automatically increase the load on the heart. If there is a higher load on the heart, what will happen? Let's see. So if there is an increased load on the heart because of increased cardiac load, that can lead to one important change. What is that? That can lead to cardiac remodeling. It will create, what is that? Remodeling. What will it create? Remodeling, cardiac remodeling. That remodeling is majorly hypertrophy of the ventricles. What is that? Hypertrophy of the ventricles. And also remember, increase of plasma volume will create edema. So the fluid will start to accumulate more in the body, creating a complaint, that is your edema. Edema is going to be what? A complaint associated with heart failure. Complaint associated with which failure? Heart failure. So that is the story of your, what is that? Story of your what happens, which systems are activated during your which activation, which disease? Decrease of cardiac output as a result of cardiac failure, right? So this much is clear, but remember, what are the other important changes which can occur? So let me tell you people, the clinical, while explaining the clinical feature, I'll tell you which ventricular failure is most likely associated with which type of symptoms, right? Now let's continue to the next important aspect. What is that? The problem here is that heart is not pumping, so we need to increase the pumping capability means we need to have a positive inotropic effect on the heart. That is one of the target of the treatment. And next important, please pay your attention to this particular point, remodeling. Now remodeling causes what? Hypertrophy. Remodeling, if it is leading to hypertrophy, so this is going to be a permanent change which can increase the mortality of the patient. So patient death rate can increase as a result of what? Remodeling and hypertrophy. So our target, my dear students, is to decrease the, very good, decrease what? Decrease the load on the heart. That is our first target. And the next important thing, also we need to increase the pumping capability of the heart. So that is what is a target of treatment, right? So once we discussed about this, let's go to the next important aspect. What is that? How do we decrease the load on the heart? By using the drugs. That is first thing. And second important aspect, is there any other changes? Yes, in the chronic heart failure. So especially remember chronic left ventricular failure. Which one? Chronic left ventricular failure. So if I have a patient with chronic left ventricular failure, what will happen? Let's see, right? So guys, please understand. So if there is a chronic left ventricular failure, so the left ventricle is failed. Okay, if there is a failure, automatically your left ventricle is not able to pump the blood out. So very simple, you have your left atria, you have your left ventricle, and you have your aorta coming out, but your left ventricle is not working. So if left ventricle is not working, what will happen? Very importantly, all the blood will pool up in the left ventricle only. So for some time the blood will start to slowly pool up in the left ventricle, but later on what will happen? It will also affect the left atria. More blood will start to pool up in the left atria. Furthermore, what it will lead to? It will lead to what is that? More blood pooling up in the pulmonary vein. So left ventricular failure automatically increase the load on the left atria. Very good. If there is an increase on the load on the left atria, now as for the time progress, there will be, very good, Deepanjali. So nowadays we use valsartan and sacubitril, but not just not just that only combination we have. We have other drug combinations also. I want you to pay attention here. If there is a decreased load on the left atria, so that will lead to increase of the load into the pulmonary vein, increase load on the pulmonary veins. If there is more blood pooling up on the pulmonary veins, automatically it will lead to congestion in the lung. It will lead to what is that? Congestion in the lung. Congestion in the lung. If there is a congestion in the lung, what will happen? The next important question we will have, that is your RBCs will start to go out of the blood vessel and creating a congestion in the lung, especially which veins? Veins of the lung are affected. Pulmonary venous congestion. Pulmonary venous congestion. So because of this pulmonary venous congestion, RBCs will start to escape the, very important, RBC escape the circulation. If RBC escape the circulation, now what will happen? These RBCs can lead to death, and these RBCs will die in the lung itself, because of which what will be there? Because of which RBC escape the circulation means if this is a vein, pulmonary vein. So what happened? RBC has come out. Now RBC, once it has come out of the circulation, what will happen? It will start to die here. Releasing which substance? Hemoglobin. So what will happen? There is a hemoglobin is released. If hemoglobin is released, that will be removed by your macrophages. So alveolar macrophages, they won't sit quietly. They rather want to remove what? Yes, they want to remove the hemoglobin, because which is normally not outside of the RBCs. So now if it has come freely, so that will be tried to removed. And if while there is a removal, what will happen? That will allow the macrophages to come and eat up the hemoglobin. So all this hemoglobin will get converted into hemosiderin, and that will be taken up by the macrophages, creating your heart failure cells from the pathology side, which is a very important. What is heart failure cell? Heart failure cells, my dear students, are a type of macrophages. What are those? Are a type of macrophages which has engulfed, very good, which has engulfed your, what is that? That is the most important, hemoglobin. The question is, heart failure cells are what? Heart failure cells are seen in, he's not going to ask you heart failure cells are seen in what? Heart failure only. All of you will answer that. He'll ask you heart failure cells are made out of what? These are the macrophages which are trying to remove, what is that? hemoglobin which has escaped the circulation, That is the story of your left ventricular failure that will lead to congestion in the lung, right? So the next important aspect, what will happen? So if there is a chronic right ventricular failure, chronic which ventricular failure? Right ventricular failure. Now let's see what is going to happen. So the most important concept, let's understand. So consider this is your right atria, right? This is your right ventricle. So this right ventricle is connecting to what is that? Pulmonary trunk, right? Pulmonary artery. All of you know it, pulmonary trunk. So now what happens? Consider if there is a failure of your, what is that? Right ventricle. If there is a failure of right ventricle, all the blood will start to pool up in the right atria. Because of which, what will happen? Right atria is communicating with which one? Yes, your superior and inferior vena cava. More blood will start to pool up in the inferior vena cava as well as in the superior vena cava. So because of the chronic right ventricular failure, yes, there is the increase of what is that? Pressure, increase of pressure or load, pressure on your right atria. If right atria is under pressure, automatically that will increase the pressure and also pooling of blood in the vena cava, pooling in the superior vena cava and also inferior vena cava. Okay, superior and inferior vena cava. So superior and inferior vena cava, if there is a increase of pressure, so automatically superior vena caval pressure is increased, that will cause JVP to increase. Very important point, increase of jugular veins pressure. And also, my dear students, they will also cause a increase of the pressure in the liver, because of which what will happen? Because of which ascites can occur. It can also cause edema. Of course, there will be edema, right? And also, my dear students, one of the most interesting question, what is that? That is going to be your congestion in the GIT also. So GIT congestion, okay, GIT congestion. So GIT congestion is the reason we find something called as a cardiac cachexia. What is that? Cardiac cachexia. Cachexia. Okay, cardiac cachexia. So what is this? Because of GIT, yes, congestion, there is no absorption of the nutrients, because of which a patient can have a weight loss called as a cardiac cachexia. So they can ask you, does heart failure cause cardiac cachexia? Yes, it is possible. So this is very important, and ascites can occur, edema can occur, and also increase of jugular venous pressure, JVP. Okay, so this is the story of your right ventricle and the left ventricular failure. Once we understood about right ventricular and left ventricular failure, let's talk about the types of heart failure. Okay, so the types of heart failure, the classification has two types. What are the two types? Let me explain you people. First one, so that is only called as left heart failure. We have something called as left heart failure. Yes, possible. And also we can have what is that called as right heart failure. What is that? Right heart failure. Okay, so we have possibly left heart failure and right heart failure. And my dear students, one of the third types is what is called as a biventricular failure, Okay, now if there is a biventricular failure, yes, that is also possible. So for us, the types are most important. Three types are there: left heart failure, right heart failure, and biventricular failure. These are the types of cardiac failure. So once we understood about the types, based on the dysfunction, based on what is that ejection fraction, also we can classify what is that called as based on the ejection fraction, we classify the heart failure. The patient will have a heart failure, yes, but what is the important catch here? The catch is heart failure with the normal or even sometimes increased of ejection fraction. So increase of ejection fraction is possible with the heart failure. So that is one thing. Usually this occurs as a result of which type of heart failure? So please remember, increase or normal ejection fraction usually seen with your most important diastolic dysfunction. What is that? Diastolic dysfunction. We can also call it as a diastolic failure. Okay, this is called as diastolic failure. The next important heart failure is heart failure will be there. Of course, heart failure will be there with reduced ejection fraction. Reduced ejection fraction. So this is one more type of what is that heart failure, which we call it as a systolic heart failure, which can also be called as a systolic heart failure or systolic failure. So here we have two types of dysfunction. There can be diastolic dysfunction, there can be systolic dysfunction. Systolic dysfunction will have a reduction of ejection fraction. Diastolic can have a normal or even increase of ejection fraction. And most importantly, based on the which ventricle is failed, so that is based upon the left ventricle means left heart failure, right ventricle means right heart failure, or both ventricles can also have a failure. So that is a classification related to your heart failure. Now, once we understood about it, the most important is the clinical features of heart failure. But before going to the clinical feature, let's talk about causes for heart failure. Okay, causes for heart failure. Now, when you look at a causes for a heart failure, so first and most importantly, remember most of the cardiac diseases, most of what cardiac diseases can make you land up into heart failure. Okay, so most of the cardiac diseases can make you land up into heart failure. So this is a very important point, such as your myocardial infarction. Yes, myocardial infarction, they can lead to what is that heart failure. So myocardial infarction, what happens, my dear students? So there is one area of the heart which has undergone necrosis. Because of this necrosis, that particular area is not working, which will lead to heart failure. Okay, then the second one is valvular diseases. What are they called as? Valvular diseases. Yes, valvular diseases can also lead to heart failure. Yes, of course. Then apart from that, remember one of the most important thing, that is your alcohol and smoking. Alcohol is a risk factor, I can say, not rather than main cause. I can call it as a risk factor of your heart failure. That is also possible. Apart from that, alcohol, is there anything else? Yes, there are other important causes such as what exactly? Cardiomyopathies. Yes, cardiomyopathies can cause. So these are the these are the diseases which are associated with the myocardium itself. So if myocardium is not working, so that will lead to cardiomyopathy, such as dilated cardiomyopathy, which we call it as a DCM. So this dilated cardiomyopathy can also make the patient land up into a systolic heart failure. Very important question. What is that? This congestive cardiac failure caused as a result of what is that? That is your dilated cardiomyopathy, usually lands up in the systolic heart failure. Please pay attention here. So now once we discussed about cardiomyopathy causing, let's go to the other important factors which are related to your what is that? Related to your heart failure. So that is in the cardiomyopathies, one more type of cardiomyopathy is there called as chronic obstructive cardiomyopathy. So that is only a hypertrophic obstructive cardiomyopathy. Then there is a dilated cardiomyopathy. Then there is a restrictive cardiomyopathy. So this hypertrophic obstructive cardiomyopathy, which does what? Which will decrease the left ventricular outlet, right? So if left ventricular outlet has been narrowed, automatically that can lead to the symptoms of heart failure. Okay, so once we understood about this, let's go to the next important concept, that is your clinical features. Okay, now clinical features of the heart failure are a very important concept but easy to understand. Okay, so first and most important, all the cardiac failure patients will have edema. Okay, which type of edema? Majority, my dear students, pitting edema. What is that? Pitting edema. Okay, apart from the pitting edema, what else can occur? So patient can have ascites. Patient can have what is that? Ascites. Okay, patient can also develop increase of jugular venous pressure, and also there is a dilation of the jugular vein. So the neck veins is going to dilate because of the heart failure. Increase and dilation of jugular vein. Dilation of jugular veins. Okay, apart from that, what else can be there? Most importantly, patient can have one of the most interesting thing. What is that? That is going to be your, my dear students, the paleness and fatigue can be there. So patient can also have paleness and your non-specific symptom, that is fatigue. But fatigue is a very important symptom also. Why, sir? Because fatigue is a symptom that is most importantly highlighting you that oxygen demands of the body is not met, right? So in the body, if there is no sufficient supply of oxygen, so that will lead to easy tiredness and fatigability, which will affect the daily activity also, right? Patient can also have, what is that? Patient can also have one of the most important pleural effusions possible. Yes, pleural effusions are also possible. So any patient, remember, any of the cardiac diseases can lead to pleural effusion, specifically when they land up into heart failure. Heart failure can lead to pleural effusion. So when we are speaking about pleural effusion, my dear students, so what type of pleural effusion we are going to find? Usually a type of transudative pleural effusion. What is that called as? Transudative pleural effusion is possible. So this is the story of your few important symptoms, but I want you to understand this, particularly this symptom, edema, ascites, JVP, these three majorly due to right ventricular failure. Right ventricular failure, majorly due to which failure? Right ventricular failure. Okay, so why am I going into all these things? I want to give you a clear idea about what are the pharmacological importances which will come to your heart failure. So that is why we are doing all this in detail. Okay, then my dear students, these can be your usually due to left ventricular failure. Okay, now once we understood about this, so if the patient is having, for example, decompensation. What is that? Decompensation. What do I mean by decompensation? Very simple. I had a patient with heart failure. Okay, I had a patient with heart failure. Now, some patient who is having heart failure suddenly develops decompensation. Means suddenly some oxygen requirement is increased or a heart is not able to pump. Now, immediately symptoms will start. Means chronic heart failure precipitated into acute heart failure. You got the point? Chronic heart failure precipitated into acute heart failure. Okay, so from now on, at least I want you to pay your most important attention. Heart failure means it is nothing to do with, it has nothing to do with your, what is that? That is it. That is your, what is that? Any other, for example, what to tell? So heart failure has nothing to do with the conditions such as your, what is that? That is your atrial fibrillation, you can say. But the problem is all of these diseases can end up into heart failure. Means you go and do any of that, have the patient with heart failure or like heart diseases can land up here. So heart failure is not one disease which is started just like that, but also because of any of the cardiac diseases it will come back, but this won't start. So if there is a decompensation, let's go to the decompensation. So decompensation happens, suddenly heart is not pumping. So what will happen? The most important, the patient will develop an acute heart failure. So if the patient develops an acute heart failure, the most important condition patient will develop is a pulmonary edema. This is the most important and dangerous condition, pulmonary edema. Pulmonary edema. So if the patient is having decompensation, it will lead to pulmonary edema. So in this pulmonary edema, what will happen? Increase of fluid accumulation in the lungs. Okay, thank you. Now, listen to me. What is that pulmonary edema? Pulmonary edema, what happens, my dear students, is a very important condition. Here, excessive fluid will accumulate. So, if there is excessive fluid accumulation, what will happen? Patient will have breathlessness. Yes, of course, breathlessness will be there. Breathlessness. Okay, so apart from the breathlessness, what else will be there? My dear students, look here in your lungs. If I put fluid, what will happen to you? You'll not be able to breathe. So you are going to have a difficulty in breathing. Automatically, your lungs are not working. So there is a decrease of oxygen saturation. Of course, there is a decrease of oxygen saturation. Okay, patient will have cold extremities. Cold extremities. Okay, this is also very, very important. Cold extremities is possible. Apart from cold extremities, what else can the patient have? So remember, patient will have crepitation. So that we'll talk as a clinical signs. Now, apart from that, patient will also have paleness. Paleness. Sometimes there can be normal or decrease of heart rate. Normal or decrease of heart rate. Okay. Now, apart from that, these pulmonary edema patients will have one of the most interesting scenario is what? Why they will get the pulmonary edema? Because acute left ventricular failure, means left ventricle is not working. Suddenly there is excessive fluid congestion occurring in the lungs. So that is what leading to pulmonary edema. So once we spoke about the decompensation that will land up into acute heart failure, the main clinical feature is your pulmonary edema. So once we understood about this, let's continue to the next important aspect. What are the investigations you are supposed to do to this person? Right? Any patient who comes to you with the acute heart failure, what and all the investigations we are supposed to do? Okay, so investigations when you are doing, I don't want you to do some blind investigation, like, so sometimes you remember na, so NCCT is the investigation of choice for head injury, right? Like that you are not supposed to do in the heart failure, because we have multiple parameters and multiple things will help you establish the diagnosis. So the first and most important investigation you can do, my dear student, chest X-ray. What can you do? Chest X-ray. Upon the chest X-ray, what can you find? Upon the chest X-ray, what you're going to find is if the patient is especially having, what is that? Pulmonary edema, or if the patient is having chronic left ventricular failure, patient can have something called as a curly B lines. So what is that? Curly B lines. Now curly B lines are as a result of excessive pressure in the lungs. So that is one helpful, and also it will show you cardiac borders. Yes. Why? Because it will tell you, for example, if there might be dilation or hypertrophy, both of them, we can get an idea regarding that dilation or your, what is that? That is your hypertrophy by looking at the cardiac borders. So once we understood about these cardiac borders, let's continue to the next important investigation. What is that? The next important investigation, my dear students, you are supposed to do a ECG. Yes, ECG will tell you what? ECG can tell you if there is any hypertrophy, right? ECG can tell you if there is any arrhythmia. ECG will tell you if there is a dilation of some chamber. So that is going to be very useful for you. So dilation of chambers will tell you a lot about heart failure. So the ECG will also help you, but it is not a confirmatory diagnosis. So is there any investigation else we are supposed to do? Yes, my dear students, one of the most important investigation what you can do is echocardiography. What is that? Echocardiography, with which you can you can look at the walls of the heart, whether cardiac movement is fine or is there any dyskinesia of the walls, and if one particular part of the myocardium is not working, we can see. And also echo will play a major role in counting, what is that? Ejection fraction. So we will call it as decrease of ejection fraction. If there is a less than 50% of ejection fraction, then we can consider about the heart failure in the patients. Now apart from echo, what else we can do? One of the most important previously many times, multiple times tested topic, that is your BNP levels. What is that called as? BNP levels. What is this BNP level? Brain natriuretic peptide levels. Brain natriuretic peptide. So what is this brain natriuretic peptide? Just listen to me very carefully. So for example, I have a patient with heart failure. Now this patient is having, what is that? RAAS activation. If there is a RAAS activation, aldosterone will be produced. Now this aldosterone, my dear students, it will cause excessive water accumulation, right? So more of fluid and sodium, So if there is a excessive fluid and sodium, now that will increase the circulating volume. If circulating volume is increased, now what will that do? That will stretch the atrias. Once the atrias get stretched, they will release a substance, BNP, which is called as a BNP. Okay, so atrias will get stretched and they can release BNP, and also atrial natriuretic peptide. So excessive volume will release BNP and ANP, atrial natriuretic peptide, brain natriuretic peptide. Now these peptide, what it will do? It will go and block the activity of aldosterone. It will go and block the activity of aldosterone. So that is the important role. So this BNP level is one of the best investigation, and also what is that? It is a marker for, what is that? It is a marker for the marker of cardiac failure. So what do I mean by this? For example, if you have a patient whose brain natriuretic peptide levels can be utilized, and we can see how much of our treatment is effective. Okay, so this is one of the important aspect about your, what is that? About your investigations in the heart failure. But out of all this, what is the most important important thing for us? Our target in this class is to target on the pharmacological aspects, right? So treatment of congestive cardiac failure. First, let's determine the targets. Let's determine the targets. So what are the targets we are supposed to keep for your treatment targets? One is to decrease the load on the heart. So decrease the load by doing what? To decrease volume load. So there is a decrease of the load by doing what? By decrease of circulatory volume, right? So if there is a circulatory volume, what circulatory volume if we need to decrease? So we can decrease the circulatory volume using many of the drugs such as diuretics. And next important, I told you people in the starting of the lecture, the RAAS system activation lead to the production of angiotensin 2. So if there is a production of angiotensin 2, that is to cause what? Vasoconstriction, right? Vasoconstriction. So if there is a vasoconstriction, now heart has to work more, but because peripheral vascular resistance will be more. So if there is a vasoconstriction, arteries will undergo contraction. If arteries are contracted, what will happen? To pump the blood through the blood vessel, your heart has to work more if there is a vasoconstriction. So we need to decrease, what is the next target? To decrease the peripheral vascular resistance. Decrease the peripheral vascular resistance. And if need to decrease the load, if you need to decrease the load, what we are supposed to do? If we need to decrease the load, we can use diuretics, which will help us reduction of sodium and water levels. Because of reduction of sodium and water levels, we can have a better advantage, that is prevention of your, what is that, remodeling of the heart, which we will talk in some time. And also we can consider inotropes, okay, inotropics. So this is the target for your treatment of congestive cardiac failure. So to understand that, first let's start with the first important group of drugs, that is diuretics which are used in the heart. So all the diuretics versus their role in the heart. So one of the most important diuretics, what can be considered is that is your potassium sparing diuretics. What is that? Potassium sparing diuretics. What is this potassium sparing diuretics? So potassium sparing diuretics such as your spironolactone. What is that called as? Spironolactone. And there is one more drug called as eplerenone. What is that? Eplerenone. So when we are speaking of spironolactone and eplerenone, all of us know the mechanism of action of this drug. So mechanism of action is very simple. They will block the aldosterone receptor. They'll block which receptor? Aldosterone receptor. So if the aldosterone receptors are blocked, what we are supposed to understand, that will cause aldosterone receptors are blocked. So that will lead to what? Yes, loss of sodium. And if sodium is going in the kidney, there is a golden rule. Sodium wherever it goes, water will follow it. So that will lead to loss of sodium and water. So if there is a loss of sodium and water, our next important question, they will also decrease the loss of potassium. So this is the target of your spironolactone. Which is the target? Yes, aldosterone receptor. So that is the story of your mechanism of action of diuretics with respect to your potassium sparing. So potassium sparing diuretics are used. So what is the advantages and disadvantages? I'll tell you people within some time, right? So these drugs, since they decrease the volume, they decrease the circulatory volume. If there is a decrease of the circulatory volume, what will happen? That will decrease, my dear students, most importantly preload. That will decrease the preload on the heart. If the preload on the heart is reduced, that prevents the remodeling. So these drugs are useful for the prevention of cardiac mortality, that is due to heart failure, because they are preventing the remodeling, because hypertrophy is not going to occur. Okay, then the next important aspect, also, my dear student, these drugs decrease the, so what is that? Yes, cardiac fibrosis. They decrease the cardiac fibrosis. So how are they decreasing the cardiac fibrosis? Majorly, they are removing the effect of aldosterone on the body, because they are blocking all the aldosterone receptors. If the aldosterone receptors have been blocked, automatically they will decrease the cardiac fibrosis. So this is the story of your potassium sparing diuretics. So these potassium sparing diuretic, if they, when they are used, right, what are the side effects which we can get as a result of potassium sparing diuretic? Yes, one of the most important, your spironolactone. All of you are absolutely correct. This spironolactone will cause gynecomastia. It will cause gynecomastia. Okay, so spironolactone will cause, what is that? Gynecomastia. So this is a first point in the side effect. Second one, these drugs increase the risk of hyperkalemia. They can lead to, what is that? Hyperkalemia. So this is a story of your aldosterone antagonist. Sir, why did we use aldosterone? Yes, let's go back and see, sir. So in this heart failure, which substance is produced? I already told you people, what is there? Aldosterone is there. So I'm trying to remove the effect of aldosterone here, right? So let's go to the next important concept. Which the drugs, the next ones? Let's talk about the drugs acting with the RAAS system, that is your ACE inhibitors. ACE inhibitors. ACE inhibitors. So these are the drugs which inhibit which enzyme? Angiotensin converting enzyme. First, let's understand. We have your angiotensin 1. Very nice. This angiotensin 1 is getting converted into, what is that? Angiotensin 2. Angiotensin 2. Now this angiotensin 2 will do what? Will cause the aldosterone production. Yes, of course. And also it will stimulate the vasoconstriction, leading to, what is that? Leading to increase of the resistance. This process was done by your one enzyme ACE, angiotensin converting. So this angiotensin converting enzyme, where is it located? Specifically remember lung. So the location also becomes important in a minute. Just please listen to me. So when this ACE is there, it was converting, but also one more thing it is doing is, it is causing this substance called as bradykinin. It is causing bradykinin also to get degraded. So degradation of bradykinin is also done by, what is that? Done by your ACE. So it is a one bullet but two targets, right? So one shot, two deaths, like that. It is converting angiotensin 1 and also it is breaking a bradykinin. So because of this, let's understand the mechanism of action of ACE inhibitor. Mechanism of action is very simple, my dear student. It will inhibit which enzyme? Yes, ACE, angiotensin converting enzyme. If angiotensin converting enzyme is inhibited, what will happen? Look at this, look at this. Yes, we have our ACE here. This ACE is not going to be there. If ACE is not there, automatically that will lead to increase of angiotensin 1 level, increase of angiotensin 1 level, increase of angiotensin 1 level, and also there will be increase of bradykinin, increase of bradykinin. So why you are specifically writing all this? Because these questions have been asked previously. Which drugs can lead to elevated level of angiotensin 1 and elevated level of bradykinin? So this elevated level of bradykinin and also decrease of angiotensin 2 levels, angiotensin 2 levels. Okay, and also my dear, decrease of aldosterone, decrease of aldosterone. So these are the two important two important points. What is that? One is with the water increased and one is water decreased as a result of ACE inhibitor. And this type of questions are previously asked many times, so you need to pay attention. So angiotensin 2 and aldosterone. Now the next important question, what I'm trying to tell, next important point is, so if they decrease, what will happen? So they are going to decrease the volume, yes, and also they are going to remove the effect of angiotensin 2. So they are going to, very importantly, they are going to decrease the preload. They are going to decrease the preload. Preload is decreased as a result of what? Decrease of aldosterone, decrease of aldosterone. And also, my dear students, they are going to cause vasodilation. They are going to cause vasodilation. Because of this vasodilatory effect, your heart can function better. So that is an advantage for us. Okay. Now, these drugs, if they're decreasing the preload and causing the vasodilation, so automatically they prevent remodeling. They prevent remodeling. They prevent remodeling. But one of the important features about this AC inhibitor, about their tolerance. Not every patient can be able to take AC inhibitor. Why exactly? We'll speak about that. So first, let me tell you people about the uses of AC inhibitor. So uses of AC inhibitor, my dear students, most importantly, where do we use them? Yes, of course, they're used in the chronic heart failure. Apart from that, as a anti-hypertensive, and they have one specific advantage, that is they decrease the proteinuria. If they're decreasing the proteinuria, where can we use them? Used in a diabetic. The use is used in diabetic mellitus patients who is having specifically nephropathy. What is the first symptom of nephropathy? So the first urinary change is the microalbuminuria. So to prevent that microalbuminuria, these drugs can be used, because these drugs will do what? Decrease the proteinuria. That is why they are used in diabetes mellitus nephropathy. So this is the story of your, what is that? ACE inhibitor. So ACE inhibitors, we have some side effects. So because of this side effect, patients are not widely using ACE inhibitors nowadays. The most important reason is this one: they will increase the bradykinin level. Because of that, they can lead to dry cough. And patient also can have one of the most important side effect, that is your hyperkalemia. They can lead to, yes, of course, hyperkalemia. Okay, and the next important point to be remembered: these patients who is having, what is that, who is having the heart failure and using these drugs, AC inhibitor, and if they have one enzyme called as C1 esterase deficiency, who is, what is that, in patients with C1 esterase deficiency, yes, C1 esterase deficiency, then they can have a increased risk of angioedema. They can have, what is that, angioedema. So this is a very, very important previously asked question in your all the competitive exams. Please pay attention. Which enzyme deficiency increases the risk of angioedema when using AC inhibitor? That is your C1 esterase deficiency. Hope everything is clear so far. I am going to continue further. What is the next important point? What are the drugs we have? The important drugs are, we have say drug called as captopril. We have a drug called as ramipril. We have one more drug called as enalapril. Okay, so most of these drugs are prodrugs. Most of these drugs are prodrugs. What are those? Prodrugs, right? So these prodrugs will come into the body. They'll get activated into something called prelat. L-A-T. Enalapril will get converted into enalprilat. Okay, so that is a story of your ACE inhibitor. And the next important group of drugs which I would like to talk about are ARBs, my dear students. What is this ARBs? ARBs are actually going to act upon, they inhibit which receptor? Yes, at AT1 receptor. Which receptor? AT1 receptor. So this AT1 receptor, where were they located? Let's recall quickly. We had your angiotensin 2, right? We had your angiotensin 2. Now this angiotensin 2 will go and activate a receptor called as AT1 receptor. What is the name of the receptor? AT1 receptor. So because of this AT1 activation, they will cause vasoconstriction and also production of which one? Very good, aldosterone, which are known aldosterone. So these both effects can be achieved by doing what? Yes, what is that? ARBs. ARBs are going to do what? ARBs are going to inhibit your angiotensin 1. So that is a mechanism of action. So, sir, what is the advantage of this drug? Okay, so C1 esterase, where it is there? Very good question. Now listen to me. C1 esterase is an enzyme which is present in the complement pathway. It is present in the complement system. Complement system is a part of your immune system which is present in the blood plasma. Clear? I hope I am clear with you, Sushil Jain. Let's continue. ARBs. So this is the mechanism of action. Once we understood about the mechanism of action, now let's go to the next important aspect. What is that? These drugs and their uses. First, let's discuss. AC inhibitor also same, all the uses will be same as that of ARBs because they are working through the same system, right? So they're used in the hypertension. Yes, they're used in the chronic heart failure. Yes. So chronic heart failure, why we are using them? Because they're decreasing the volume by blocking aldosterone activity, by not producing the aldosterone. And the next important thing, they will also decrease the preload by effect of vasodilation. Preload by decreasing the, what is that, vasodilation. So this is the two important points: decrease of preload, decrease of volume, and also there will be a decrease of yes, your, what is that, chances of mortality, decrease mortality. Why it will decrease mortality in this patient? Yes, as I said, if load is more, heart has to work more. If heart has to work more, what will happen? Yes, what will happen? The patient will have hypertrophy of the heart. If that hypertrophy is not there, then we have removed the hypertrophy. That means we are preventing the death of the person. So that is your, what is that, advantage of your ARBs. Apart from hypertension, congestive heart failure, yes, these also used in the diabetes patient with a nephropathy. Diabetes nephropathy also we can use. Sir, what is the advantage? Yes, these drugs has no dry cough. Yes, no dry cough. Okay, and if there is no dry cough, what else will be the advantage? Remember, my dear students, no angioedema. So if no dry cough and no angioedema, yes, they are going to be better than, yes, they are better drugs than your AC inhibitor. So these are well tolerated and very commonly used instead of AC inhibitors. Okay, so this point you need to remember. What are the advantages of ARBs? Two main advantages. What is that? No dry cough, no angioedema. These are the two major advantages of ARBs over ACE inhibitors. This is also a very important point for you. Let's continue to the next interesting thing. What is that? What are the drugs? All the drugs will have ending, what is that, sartan in them. What is that sartan? Such as losartan, such as telmisartan. What is that? Telmisartan. Such as the valsartan. Okay, such as valsartan. All these sartans are doing what? All the sartans are used as a drugs used in the heart failure because they prevent the remodeling, right? So the next important, what is the next important group of drugs which can be used, my dear sir? So the next important drugs which can be used is what is that? We can use beta blockers. We can use which ones? Beta blockers. Beta blockers. So beta blockers, please remember. So clinical aspect which is most importantly asked is, so these drugs first they will block the beta 1 receptor. If they're blocking the beta 1 receptor, automatically they're decreasing, what is that, O2 demand of the heart. O2 demand of the heart. Okay, they're not used as a monotherapy. So whenever a patient is having, what is that, heart failure, we are not going to use only beta blocker as a drugs for the treatment of heart failure. So what exactly we are going to do? Not used alone, but rather we are combine them with other drugs. They're combined with the ACE inhibitor, with ACE inhibitor, and also ARBs, ARBs. So these are the two groups of drugs. We can combine them. Always remember, when you are starting beta blocker in the heart failure, always start with a low dose. Start with a low dose and slowly start with a low dose and slowly increase the dose. Start with the low dose and you can increase the dose. You can increase the dose. Increase the dose slowly. Okay, so this is the story of your beta blockers. So which type of beta blockers are preferred? Preferred is selective beta 1 blockers. Selective which blockers? Beta 1 blockers. Selective which blockers? Beta 1 blockers. Clear? So beta blockers are used. Apart from the beta blockers, I want you to understand what are the other groups of drugs which are used. Other groups of drugs which are used, we can also use thiazide diuretics. Thiazide diuretics. And there is one more loop diuretic. Loop diuretics comes with the acute heart failure. That pharmacology will speak separately. right? So once you understood about this, what is the next important? So ionotropic agents. What is that? Ionotropic agent. So these ionotropic agents which we are going to use, my dear students, that is only your digoxin. Okay. Now digoxin is a type of ionotropic agent, but see this ionotropic agent. So ionotropic agents will increase the heart rate, sudden force of contraction suddenly, but digoxin will not increase suddenly because it is having a slow onset of action. So how do we use digoxin, and why don't we call it as a mainstream ionotropic? Why? What is the advantages and disadvantages of digoxin? Let's discuss. So to understand digoxin, it is a type of plant derivative drug. It is a type of plant derivative. So plant derivative from which plant? Yes, from the digitalis plant. Okay, this digitalis plant itself is called as foxglove plant. So this foxglove plant, how it will work? So to understand that, let's start with the mechanism of action. So the mechanism of action, my dear students, the first and most important mechanism of action, it will bind with the potassium site of sodium potassium ATPase. Which site? Sodium potassium ATPase. Okay. So if it binds to this particular site, what will happen? Let's see. Right. So when you consider you have a heart failure patient and you are giving this digoxin, how exactly it will work, we are learning here. So basically every time cardiomyocyte undergoes depolarization, that will allow the entry of sodium. So once sodium has come into the cell will become more and more positive. It will undergo depolarization. Later, what will happen? So first, there was a cardiac depolarization. The cell was at rest. The resting membrane potential was minus 90 millivolts. As a result of sodium entry, the voltage has been increased. But after some time, what will happen is sodium channels are closed, right? So this is only your phase 0. This is only your phase 0 of the ventricular depolarization. Then what will happen? Your potassium channels open up, my dear student. Which channel open up? Potassium. So potassium is slowly going out. So as potassium is slowly going out, voltage will also slowly, slightly will start to fall. But during this time, as a result of voltage generation, it will open up something called as calcium channels. Right? So it will open up the calcium channels, and calcium channels will allow the entry of calcium because free calcium outside of the cell is more. Now what is happening? Potassium is going out, calcium is coming in. Potassium is going out, calcium is coming in. So because of that, voltage that is will remain the flat line. Voltage will remain the flat line. But see, our body is designed very beautifully. What do I mean by beautiful design? So the design, see, as soon as I say the design, people are going into wrong thought. Now come back here in the heart. What happens? The property of potassium channel. The property of potassium channel is that these potassium channels are long acting in nature as compared to that of calcium. So because these potassium channels are long acting, while your calcium channels are slow acting compared to that of so long acting and short acting compared to that of potassium. So remember which one is long acting? Potassium. Which one is short acting? Calcium. So calcium channels will close, but potassium will keep on going out. That will allow the cell to come back to its original state called as resting membrane potential. Okay, sir, what is the use of this? This calcium is the reason. What will happen, my dear students? Contraction will occur. What will occur? Contraction. Now please understand, the question comes to us is how digoxin is playing a role in all this. So on the other side of the myocardium, you can see, so in the all the cells will have, what is that? Sodium, potassium, ATP. So they will be sending the sodium out of the cell and they will be taking the potassium into the cell to maintain the normal physiology. In the normal physiology, you have already read, inside of the cell, the potassium level is more. The potassium level is more, and outside of the cell, potassium level is less. So to maintain this balance, continuously one pump is working, sodium, potassium, ATPase. Right? Now digoxin will come and block this. Okay, so what will happen? The sodium inside the cell will increase, my dear students. What will block it? Digoxin will block it. So sodium inside the cell will increase. If more sodium in the cell, now what will happen? Inside the cell there is a more sodium. Now on the other hand, we have something called as a sodium calcium exchange. What is that? Sodium calcium exchange. So what is this sodium calcium exchanger is doing? This is also a very interesting. So it will allow the movement of sodium and calcium. It will allow the movement of sodium and calcium. So what it was doing, it was sending the calcium outside. It was sending the calcium outside, and it was taking the sodium inside. Okay. Now what will happen if there is more sodium? So more sodium is already more inside the cell. Sodium is already more inside the cell. If sodium is already more inside the cell, it cannot bring any more of sodium, because this exchanger will not be able to work against the concentration, because more sodium is already present inside the cell. Because of that, this exchanger will fail. So if this exchanger fails, sodium will not also go, and also, my dear students, what is there? Calcium will not come out. So if calcium will not come out, it will increase the calcium in the cytoplasm. So simple, if sodium potassium ATPase is inhibited, so that inhibition will lead to increase of intracellular sodium, that will in turn increase the intracellular calcium. If calcium is more, automatically increase of contractility of the heart. So if there is an increase of contractility of the heart, now what will happen? Ejection fraction will be improved. But most importantly, you might ask me, sir, if you are increasing the contractility of the heart, why to use any other drug? Just we can solve the problem. But remember, it will not have, it does not prevent any cardiac remodeling. So this does not prevent. This is the main reason why digoxin is not widely used clinically, because does not prevent the remodeling. So automatically what is going to happen? Remodeling can occur, and that can lead to death of the patient. So which drug does not prevent the mortality in cardiac failure? The answer is digoxin. Okay, so does not prevent the remodeling. This is one important point. And about digoxin, my dear students, it will cause some important effects. So what is that side effects caused by digoxin? I will tell you. So the first and most important side effect is arrhythmia. What is that? Arrhythmia. Okay, so arrhythmias are very common with digoxin. And the next important side effect associated with the digoxin, you need to remember, it can cause nausea, vomiting. So now you can tell me, sir, in pharmacology, for everything we will tell nausea and vomiting as a side effect. Okay, now many people does this mistake, going and telling nausea and vomiting as a side effect for antiemetics. At least don't do that. Okay, now you might ask me, sir, nausea and vomiting can occur with anybody else, right? Remember, nausea and vomiting can occur with any drug also, but here, because of one property of the digoxin, because of vagomimetic action. What is that? Yes, vagomimetic action. And patient can also have a decrease of heart rate. Yes, that is also possible because of the same effect. Vagomimetic means it is increasing the activity of vagus nerve. Okay, so decreases the heart rate. So, and also patient can have weakness very easily, because sodium potassium ATPase, which is present inside the muscles, can also get affected, and this can also cause, what is that? Yes, drug can cause accumulation. What is that? Accumulation can occur where exactly? Mainly in the skeletal muscle, and digoxin also leads to gynecomastia. And apart from that, the patient can also have one more side effect. What is that? So this digoxin will cause gynecomastia. That part is clear. But this digoxin, whenever it is given, this can become toxicity very easily. And remember, the digoxin, whenever it is given, this drug will go out of the body unmetabolized. So it can also cause toxicity to the kidney, nephrotoxic. It can cause nephrotoxic. Okay, especially if the patient is having a renal failure, then it is even more easily digoxin toxicity can occur. And also it will lead to ECG changes. So these are the side effects caused by the digoxin. So digoxin is not clinically widely used. When do we give? So we give digoxin usually considered during in one condition, New York Heart Association class 3 and class 4 patients, we can consider digoxin. But most importantly, it has a narrow therapeutic index. Since it has a narrow therapeutic index, so we must mandatorily do, what is that? TDM. This is also very important point. So therapeutic drug monitoring is required. So this is also one more important disadvantage related to digoxin. Once we understood about it, the next point of digoxin. What is that? This digoxin can become, what is that? Overdose, digoxin toxicity. So toxicity of digoxin, first and most important, who will cause and how will digoxin toxicity can occur. So the factors to increase, factors which increase the risk of, factors increase the risk of what? Risk of digoxin toxicity. Let's talk about it. Okay, so when we are speaking of toxicity, remember the patient, if he is not able to send the digoxin out of the body, it will start to accumulate inside. So which condition? Yes, patient with a renal failure. So renal failure patient can easily get a toxicity with the digoxin because he is not able to clear the drug out of the body. Apart from renal failure, where else we can what else can cause this? The hypokalemia. Hypokalemia. So hypokalemia means there is a low level of potassium in the body already. If potassium levels are low in the body, then it can lead to toxicity very easily because digoxin and your potassium are competing for the same site in the sodium potassium ATPase, right? So apart from that, hypokalemia usually caused by, remember, your thiazides and loops, thiazides and loop diuretics. These are the two drugs which can lead to, what is that? Hypokalemia. So once we understood about this, one more electrolyte imbalance called as a hypercalcemia. Hypercalcemia can also lead to toxicity of digoxin very easily. So if the patient is having a digoxin toxicity, so what is the most important thing? Clinical feature. So clinical feature, there will be the like side effects only, but there will be some of clinical feature which will be exaggerated also. What is that? Patient can have excessive weakness. Excessive weakness, yes. The patient can have arrhythmia, right? Patient can also have, what is that? Yellow vision, yellow halos. Okay, he will tell, today I am the god because there is a sun around me, around my head. I'm feeling as if I'm having a yellow color light and yellowish vision. So that time also we need to think of what is that? Digoxin toxicity. Okay, so the most important aspect, arrhythmia, if the patient is having, what you are supposed to do, drug of choice for arrhythmia caused by digoxin is lidocaine, is your lidocaine. And the next important antidote for your digoxin toxicity, this is also a widely made mistake. The antidote is called as digoxin immune F antibodies, digoxin immune F antibodies. This is the antidote for which toxicity? Digoxin toxicity, which can also be known as digibind. But most of the time in the exam, what will happen? The examiner is very brilliant. He'll do what? He'll give you all the symptoms and he'll tell everything. And what is the cause? Like what is the treatment for digoxin toxicity? Now, digoxin toxicity, most of the students, what will they do is that they will remember, digibind, 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 digibind. Okay, wahan pe jaoge, you'll go there and you'll play, where is digibind? Oh my god, there is no digibind. Then what to do? Then immediately, the next one I know is lidocaine. Sir, I will mark lidocaine and come. I will give you 0. Why? Because the last option will be, what is that? Digoxin immune F antibodies will be written. So remember, digoxin immune F antibody is the drug of choice for the treatment of your, what is that? That is your digoxin toxicity. The drug of choice lidocaine is always which one? For digoxin induced arrhythmia. Okay, so many students have made this mistake, and this blunder has happened not even like anytime very earlier, very recently in last 2 to 3 years itself. So in the NEET exam there was a question and this did happen. Okay, now when we are speaking of digoxin and antidotes, we understood other treatments. What we can do is, my dear student, potassium level correction should be done immediately. Potassium level correction should be done immediately. And if there is a digoxin overdose is too much, then we can also consider dialysis. So they can ask you, all of the following are used in the treatment of digoxin toxicity except, so that time it's very, very important to pay your attention. Okay, so once we understood about these clinical features of digoxin, the next important question what we are going to understand is, any other drugs do we have? Yes, we have some newer drugs in the newer drugs in the treatment of chronic heart failure. So the newer drugs, what and all we have, let's start with the first and most interesting drugs, that is you are called as a neprilysin inhibitor. So what is this neprilysin? Then we don't know that also. So first let's understand the neprilysin. So all of us know one important aspect called as BNP. What is that substance was called as BNP? What was there? BNP, brain natriuretic. So this brain natriuretic peptide, the action is very simple. The action of brain natriuretic peptide is what? It will inhibit the aldosterone activity. If aldosterone activity is inhibited, then what is going to happen? It will cause a loss of your, very good, what is that? Loss of your sodium. But this brain natriuretic peptide undergoes metabolism, means it will undergo breakdown. Okay, metabolism by the help of one enzyme called as NEP, that is only called as neprilysin. Okay, so neprilysin is the enzyme which will break down the brain natriuretic. So if brain natriuretic peptide, if it is broken down, now what will happen? Yes, that is going to lead to a problem. That is, what is that? Reduced level of BNP. So aldosterone activity will be still there. So we need to prevent that by using some drugs that is only called as NEP inhibitor. What is that? NEP inhibitors. What is that? NEP inhibitors. Okay, NEP inhibitor. So that NEP inhibitor is actually the drug which already one of you commented. Who's that? So I think Deepanjali More, you commented sacubitril plus valsartan. So that's sacubitril. What is that? Sacubitril. So this sacubitril, my dear students, is a NEP inhibitor. So usually it is combined with yes, we are going to combined with one of the most important sartan, that is valsartan. That is your valsartan. So this is a approved combination for the treatment of congestive cardiac failure in many countries, specifically India. So the best approved combination is sacubitril plus valsartan. But along with this, further management, we can have beta blockers. For example, we can consider your that is aldosterone antagonist also can be considered. So this is your neprilysin inhibitor, sacubitril. And also we have one more drug, my dear students. What is that one more drug? That is your BNP analog. What is that? BNP analogs. BNP analogs. So the name of the drugs, BNP analog, is a type of drug called as nisiretide. Nisiretide. What is the name of the compound? Nisiretide. This nisiretide is used as a BNP analog. So this BNP analog is also a very important question. Now the latest, even more newer drugs are there. What is that advantage of those drugs? Let's see. So what is there? That is called as ACE is one enzyme. One culprit was ACE. So ACE and one more culprit was neprilysin. So both of these enzyme ACE and neprilysin inhibitor. So we are trying to inhibit both of them, ACE and neprilysin. So that drugs include your omapartilate. What is the name of the drug? Omapartilate. Okay, so every drug, this group has the AC and neprilysin, they will end with partilate, omapartilate. This is one of the very important drugs to be remembered, because they can ask you which of the following is a ACE plus NEP inhibitor. So this can be the MCQ possible for you people. Then apart from that, there are other groups of drugs which are widely used in the treatment of acute heart failure. I will talk about the acute heart failure treatment also. But most important three drugs, newer drugs: sacubitril, nisiretide, and your what is that? Omapartilate. Okay. So let's go to the next important drugs used in what? Very important, acute heart failure. Acute heart failure patient comes to you with what is that? Let me quickly revise it, people. Acute heart failure is there, pulmonary edema will be there, patient will have decreased saturation. So patient is going to have what is that? Difficulty in breathing, shortness of breath, orthopnea can be there. Apart from orthopnea, what else can come to the, what else the patient can complain of? The patient can complain of what is that? Feeling fatigue, weakness. All of these things will be there. When you auscultate, crackles can be there. So majorly crackles will be bilateral, basal crepitations, usually, but later it will become the whole lung. Then we are going to do a chest x-ray. When chest x-ray is done, what we can find? Bat wing appearance due to pulmonary edema. So if this person comes to our hospital, what we are supposed to do? First and most important, any patient comes to the hospital, drugs used in acute heart failure, even before that, you are supposed to give O2 supply. Yes, you are supposed to give the oxygen therapy. Then also we are going to use a PAP. What is that? Positive airway pressure ventilation. What is that? Positive airway pressure ventilation is very, very important. Positive airway pressure ventilation is a very important thing we are supposed to give for the patient. Apart from that, we can use, what is that? Inotropic agent. Inotropics, which are the drugs we have? Any drug which stimulates a beta 1 receptor. Beta 1 agonists are widely preferred drugs. So beta 1 agonists are widely preferred drugs are your, we have a drug called as dobutamine. We have a drug called as dobutamine. Okay, and we have one more drug called as dopamine. Okay, so if you ever get a question, what is the drug of choice for acute heart failure? Remember, it is your dobutamine. So the inotropic of choice is the dobutamine. Drug of choice, inotropic of choice is the dobutamine. Never make this mistake. The inotropic of choice is dobutamine. Okay, so dobutamine, and also we can use dopamine, but dopamine has one interesting thing. It will show dose dependent action. It will show, what is that? Dose dependent action. Okay, so dose dependent action, what do I mean by this? So dose dependent action, because dopamine, when given at a higher doses, it will act upon, what is that? Alpha 1 receptor and also dopamine receptor. If it's given at a medium doses, it will activate beta 1 receptor and D1 receptor. At low doses, it will activate the dopamine receptor. So these are some important points to be remembered. So remember, whenever we have, for example, what is that? Dopamine. So dopamine, my dear students, shows dose dependent action. So dopamine will become drug of choice when? Dopamine is a drug of choice in a patient who is having acute heart failure with, what is that? Oligouria. Yes, some people can develop oligouria, that is lack of urine, because of, what is that? Decreased blood supply to the kidney. So listen to me. Acute heart failure, decreased pumping capability, decreased blood supply to the kidney. So kidneys are shutting down because they're not able to generate any urine, because they're not getting any blood supply. So that time dopamine will become the drug of choice, because dopamine will go and stimulate the D1 receptor. If they stimulate the D1 receptor, remember, it will cause vasodilation in the kidney. It will cause vasodilation where? In the kidney. So if vasodilation occurs in the kidney, renal blood flow will increase. So that will lead to increase of flow of the blood. So that will increase the blood flow. If there is an increase of the blood flow to the kidney, automatically what will happen? Increase the urine output. So that is why any patient with the oligouria plus acute heart failure, the best drug is dopamine. So whenever you give dopamine, there you are going to monitor something, that is going to be your urine output, my dear student. That is going to be your which one? Urine output. So apart from dopamine's D1 action, dopamine will also stimulate at which dose? Medium dose. At which dose? Medium dose. It will activate the beta 1 receptor, which will cause the inotropic effect. Okay, that improves the contractility. And it can also have a effect on the blood pressure also. So that is why whenever you are using dopamine, you are supposed to monitor the heart rate, blood pressure, and also you are supposed to monitor the urine output. Okay, so apart from that, we have other drugs called as the PDE inhibitor. What is that? PDE inhibitor. So as soon as I tell you PDE inhibitor and heart failure, so many people will be tell me, what is that drugs? Sir, sildenafil, tadalafil, they are your PD5 inhibitors. Okay, so here in the heart we have actually PD3 inhibitors. Okay, so these PD3 inhibitors, such as amironone. Okay, and there is one more drug called as milrinone. Okay, so amironone and milrinone. So these drugs can cause one side effect. The side effect is usually decrease of platelets. Decrease of platelets is possible. Okay, but best commonly used drugs and widely questions also asked is from your ionotropic agents. Which agents? Ionotropic agents. Okay, so these are the drugs used in the acute heart failure. But we also have a patient with pulmonary edema, right? So for that only we are going to use one more group of drugs, that is your loop diuretics. What is that? Loop diuretics. So loop diuretics are given which drugs? Specifically your furosemide, specifically your furosemide. So furosemide, what it is going to do? The furosemide specifically used for one particular reason, that is for the pulmonary edema. For the pulmonary edema. Okay. And also we can use one more important aspect. What is that? Yes, we can consider arterial dilators and venodilators. So we can use your venodilators. So venodilators which are widely used for the treatment of congestion. Venodilators are widely used for congestion treatment. Which drugs are considered? Yes, nitrates are used. Which drugs? Nitrates are used. Right? So nitrates causes the venodilation. So whenever organonitrates are given, just I will give you a recap from the nitrates, because these are not a mainstay treatment, but you need to understand nitrates. Always remember, once they enter the body, they will get converted into NO, that will activate a cascade of secondary messenger. Because of that, the smooth muscle relaxation. Now, the smooth muscle relaxation, whenever nitrates are given, its major effect in the blood vessel mainly seen first effect on the veins only. So, nitrates acts first on the vein, then acts upon the other arteries. Okay, so nitrates are used for congestion. And remember, arterial dilators. Arterial dilators are used for the improving of the blood supply, because if arteries are dilated, that will decrease one of the most important afterload. That will decrease, what is that? Afterload on the heart, because pumping can occur very easily now because of that. So these arterial dilators were such as your hydralazine. Hydralazine is used. Which drug is used? Hydralazine is used. So hydralazine, arterial dilator, yes, that can be considered for your treatment of improving the blood supply. So this is a story of your, what is that? That is your arterial dilators and venodilators role, specifically in the treatment of, what is that? Heart failure. Once we understood about this, I want you to pay your attention. What are all the important points which we must remember? So remember, heart failure. What can cause heart failure? So the causes for the heart failure are due to MI. Any of the cardiac diseases can end up into heart failure, but heart failure will not suddenly start from, like, night I was sleeping, I woke up in the morning, I have a heart failure. That does not start like that, but that will start as a result of other conditions. Now, heart failure, once it is there, that will decrease the pumping ability, that will cause the sympathetic activation. That sympathetic activation is the most important role player in the heart failure, because of sympathetic and RAAS activation, that will lead to excessive fluid load, yes, edema, yes, and cardiac remodeling. And remember, aldosterone and angiotensin too, they can even directly act on the heart, and they can induce fibrosis. So we are supposed to prevent the remodeling. Remodeling can be prevented using spironolactone, that is your diuretic. The drugs which are beta blockers can be considered, ACE inhibitors can be considered, ARBs can be considered, even thyroid diuretics also can be used for the prevention of remodeling. But one of the most important four groups, if I ever ask you, spironolactone, yes, ACE, ARB, and one more important one is that is your beta block. Beta blockers start with the low dose, go for the high dose. Then we can use that is digoxin. Digoxin is usually preferred in the 3rd and 4th NYHA classification, but it is not preferred because it is having a narrow therapeutic index, highly toxic drug, accumulates in the body. It can become overdose very easily. We need to monitor the therapeutic. Drug monitoring is required. That is a disadvantage for us. And digoxin does not prevent the remodeling, and digoxin is a vagomimetic, and antidote of choice for you people is digoxin immune F antibodies. Digoxin immune F antibodies. Apart from that, the next important newer drugs, I want you to remember 3 of them: sacubitril, yes; nisteretide, yes; and also vomapartilol. right? Then we have drugs used in the acute heart failure. Some are inotropes such as dopamine, dobutamine, and also we can use loop diuretics. Of course, positive pressure ventilation, oxygenation must be there, and most importantly, venodilator and arterial dilators are used for the retrieval of congestion, that is for the nitrates, and arterial dilators such as hydralazine can be used. Okay, so this is the story of your heart failure with respect to pathology little bit, medicine little bit, and markers everything. So if you know this much, any of the competitive exams you'll be able to ace it very easily. So that is the session for today. Thank you. See you people next time.